Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning, Mrs. Thompson. It's nice to see you again. How have you been feeling since our last appointment?
Good morning, Doctor. Well, no, I've been managing, but the knee pain from my osteoarthritis has been pretty persistent. I've been taking the ibuprofen you prescribed, which helps a bit, but the pain still feels quite high, especially on some days.
I'm sorry to hear that. Can you tell me more about how the pain has been affecting your daily activities?
Sure. The pain usually starts in the mornings when I wake up, and sometimes after I've been sitting for a while. Getting out of bed or standing up can be really tough. Walking around the house or running errands isn't as difficult as it used to be, but it still takes a lot out of me. Climbing stairs is becoming increasingly challenging, and I've had to cut back on some of my activities because of the pain.
I understand. Have you noticed any changes in the intensity of the pain throughout the day?
Yes, the pain tends to fluctuate. It starts off pretty intense, around an 8 out of 10, and after taking ibuprofen, it usually comes down to about a 6. But there are days when even that level feels overwhelming, especially if I've been on my feet for too long.
Have you tried any other pain management strategies aside from ibuprofen and tramadol?
I've been using heating pads on my knees, which provide some relief. I also tried stretching exercises a few weeks ago, but I found it hard to stay consistent because of the pain. I haven't started physical therapy yet, but I've been considering it as an option.
It's good that you're exploring different methods. Let's talk a bit about your overall health. How have you been managing your blood pressure and diabetes?
My blood pressure has been a bit elevated lately. Last time it was 143/70. I'm taking lisinopril, amlodipine, Bumex, and metoprolol, but I've been having trouble keeping up with the metoprolol regimen. I was supposed to take it twice daily, but I've only been taking it once because I sometimes forget the second dose. My blood sugar levels have been controlled, staying in the 140s to 150s, and my last A1C was 6.6, which I'm pretty happy about.
That's good progress on your diabetes. We'll need to address the blood pressure management. How about your cholesterol levels?
My cholesterol levels are within normal limits, which is a relief. I was worried because of my history, but everything seems to be under control there.
That's excellent. How are you handling your medications overall? Any side effects or difficulties?
Mostly, it's been manageable. The only issue is with the metoprolol, as I mentioned. Sometimes the ibuprofen gives me a bit of stomach discomfort, but taking with food helps. Other than that, I haven't noticed any significant side effects from the other medications.
Understood. Let's discuss your lifestyle a bit. You mentioned working night shifts. How is that affecting your sleep and daily routine?
Working night shifts has really messed with my sleep patterns. I usually try to sleep from around 10 a.m. to 3:30 p.m., but it's not always consistent. I often feel tired during the day, which probably doesn't help with managing my pain or keeping up with my medications.
Sleep is crucial for overall health, so we'll keep that in mind. How about your diet and physical activity?
I try to eat a balanced diet with plenty of vegetables and limit sweet and high-fat foods. I do have fried foods occasionally, but I'm making an effort to keep them to a minimum. My BMI is 31, so I'm aware that I need to manage my weight better. Exercise is limited because of the knee pain, but I try to take short walks when I can. I'm not very active otherwise.
Managing weight can indeed help with the knee pain. Have you considered any weight management programs or support?
I've thought about it, but I haven't taken any concrete steps yet. Maybe with better pain management, I could be more active and start something like that.
That sounds like a good plan. You also mentioned a history of smoking in the 1970s. Have you had any respiratory issues since then?
No, I haven't had any significant respiratory problems. I quit smoking a long time ago and have been mostly healthy in that regard.
That's good to hear. Have there been any other health concerns or symptoms you'd like to discuss?
No major issues, but I am a bit worried about my blood pressure. Also, I'm considering retirement soon. I want to focus more on personal activities, like fishing, but I'm concerned about how my health will impact that plan.
Retirement sounds like a wonderful goal. We'll work on managing your health to support your plans. Now, let's go over your recent lab results and vital signs to get a clearer picture.
Okay.
The X-rays of knees showed joint space narrowing and subchondral sclerosis, which are indicative of advanced osteoarthritis. Your echocardiogram from last year showed normal left ventricular function with an ejection fraction of 60%, which is good. Given your history of smoking, we plan to conduct an abdominal ultrasound to check for aortic aneurysm.
Yes, I remember you mentioning that.
Based on everything we've discussed, here's the plan. To better manage your blood pressure, we'll increase the dose frequency of metoprolol to twice daily as originally prescribed. I'll also renew your tramadol prescription for pain management to help reduce your reliance on ibuprofen. The abdominal ultrasound will be scheduled to screen for aortic aneurysm due to your smoking history. You'll continue with your current medications and will monitor their effects closely. Additionally, we'll schedule a follow-up in 6 months to recheck your cholesterol and other parameters. I'd also like to discuss potentially increasing your dietary fiber intake to improve bowel movements.
That sounds comprehensive. I'm glad we're addressing these issues. I really want to enjoy my retirement and fishing without being held back by pain or other health problems.
Absolutely. Managing your pain and blood pressure effectively will be key to maintaining your quality of life. If you have any concerns or experience any new symptoms before our next appointment, please don't hesitate to reach out.
Thank you, Doctor. I appreciate your help.
You're welcome. I'll have the prescriptions renewed and set up the ultrasound appointment for you. Take care, and we'll see you in 6 months.
Thanks again. Goodbye.
Goodbye.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Hi, doctor. Thank you for seeing me today. I've been dealing with this persistent cough for a while now, but it seems to be getting worse lately. It's especially bad later in the day, usually after I've eaten. Lately, I've also started experiencing these heart palpitations whenever I cough.
I'm sorry to hear you're going through this. Can you tell me more about when the cough started and how it has changed over time?
Sure. It started about 6 months ago. At first, it was just a mild cough, but over the past few months, it's become more frequent and severe. It's particularly bad after meals, which makes me think it might be related to my acid reflux. I've had acid reflux before, and the medications I took back then actually caused me to cough more, which was really frustrating.
That does sound challenging. Have you noticed anything else that might be related to your cough or the palpitations?
Well, aside from the cough and the heart palpitations, I haven't had much relief from the reflux medications I've tried. I'm not taking any over-the-counter remedies like Sudafed right now. I also don't have a history of smoking, which I know can cause coughs, so that rules out one potential cause. I've been trying to stick to low acidic diet and even monitor my pH levels, but nothing seems to help. I've stopped drinking coffee and switched to tea, but the cough persists.
I see. You mentioned that the heart palpitations started recently and are associated with coughing. Have you had any other symptoms like dizziness, shortness of breath, or chest pain?
No, nothing like that. It's just the palpitations that come with the coughing spells. I did have some tests done last year, including a stress test and checking my TSH levels, cholesterol, and pulmonary function, but everything came back normal. Despite following the medical advice and trying different treatments for acid reflux, my symptoms haven't improved, which is really frustrating.
I understand how that can be frustrating. How has this affected your daily life?
It's been quite disruptive. The persistent cough interrupts my work and social activities. The heart palpitations are scary and make me anxious, especially since I don't fully understand what's causing them. I'm really frustrated with the lack of improvement despite following all the recommendations. I feel like I'm just going in circles without a clear diagnosis or effective treatment plan.
That sounds very difficult. Have you noticed any specific triggers besides eating that make the cough worse?
Not really. It seems to be more related to the timing after meals. I also don't have any symptoms of postnasal drip or sinusitis, and my chest x-ray didn't show anything acute. I've been trying to avoid acidic foods and sodas, and I haven't noticed any improvement from those changes either.
You've been very thorough in managing your diet and following up on your symptoms. Can you tell me more about your lifestyle? For instance, your work, stress levels, or any other factors that might be relevant?
I work a desk job, so I'm pretty sedentary during the day. I've been trying to stay active by walking in the evenings, but the cough makes it hard sometimes. Stress-wise, it's been up and down, mostly related to dealing with these health issues. I don't consume much caffeine anymore, only occasional tea. My family has a low acidic diet, and I try to keep up with that, but it's been tough to manage everything on my own.
It sounds like you're making significant efforts to manage your condition despite the challenges. Have you had any recent investigations done to further explore your symptoms?
Yes, last year I had an EKG, and it didn't show anything concerning. The doctor suggested doing a Holter monitor and an echocardiogram to get a better look at my heart rhythm and structure. There's also been talk about possibly getting an upper GI study to investigate my reflux more thoroughly, but I haven't started that yet.
Those tests should help us get a clearer picture of what's going on. Given your symptoms and the lack of response to initial treatments, it's important that we continue to investigate both the respiratory and cardiac aspects. Is there anything else you'd like to share about your symptoms or concerns?
I guess I'm just really hoping to find a definitive diagnosis soon. It's hard not knowing what's causing all this and feeling like the treatments aren't working. I'm also hesitant to start new medications without understanding the underlying cause better. I want an effective treatment plan that addresses the root of the problem, not just the symptoms.
I completely understand your concerns and frustration. We'll work together to get to the bottom of this. Let me summarize your current status. Your vital signs are stable, with a blood pressure of 130/85, heart rate of 88 BPM, respiratory rate of 18 breaths per minute, temperature of 98.6 degrees Fahrenheit, and oxygen saturation at 97% on room air. Your laboratory results are within normal ranges across the complete blood count, basic metabolic panel, liver function tests, and thyroid function tests. Your chest X-ray and sinus X-ray didn't show any acute issues, and your spirometry results are slightly below predicted values but not significantly abnormal. Given your persistent cough, especially postprandial, and the new onset of heart palpitations, we need to proceed with the planned investigations. These include wearing a Holter monitor to capture any abnormal heart rhythms over a 24-hour period, scheduling an echocardiogram to assess the structure and function of your heart, and potentially conducting an upper GI study to evaluate the extent of your reflux and rule out any complications like a hiatal hernia or Barrett's esophagus. Our assessment is that your symptoms may be multifactorial, potentially related to gastroesophageal reflux disease, that might be causing both the cough and triggering the heart palpitations through vagal nerve stimulation or other mechanisms. However, we need to rule out any cardiac causes given the palpitations. The plan is to proceed with the Holter monitor and echocardiogram as soon as possible to gather more data on your heart's activity. Concurrently, scheduling an upper GI study will help us better understand the role of acid reflux in your symptoms. Once we have the results from these investigations, we can develop a more targeted treatment plan to address both the cough and the palpitations effectively. Is there anything else you'd like to discuss or any questions you have about this plan?
No, that makes sense. I appreciate you taking the time to explain everything. I just want to get to the bottom of this and find some relief.
Absolutely. We'll work together to find the best solution for you. Let's schedule those tests and follow up once we have the results.
Thank you, Doctor.
You're welcome. Take care, and we'll talk soon.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Good morning, John. How are you feeling today after your surgery?
Morning, Sarah. I'm feeling okay, but a bit sore and a little anxious about the recovery process.
That's completely normal. Let's go over your rehabilitation plan to ensure you're comfortable and confident moving forward.
I'd appreciate that. I'm eager to regain my mobility, but I'm not sure what to expect.
Absolutely. We'll start with gentle range of motion exercises to reduce stiffness and improve flexibility. This will be done daily for the first 2 weeks.
Sounds manageable. How soon can I start walking again?
With your surgery being successful, you can begin partial weight-bearing exercises within a week, using a walker for support. We'll gradually increase your walking distance as your strength improves.
What about pain management during therapy sessions?
We'll coordinate with your physician to ensure your pain is well controlled. It's important to work through exercises without excessive discomfort to promote healing.
How long will the entire rehabilitation process take?
Typically, full rehabilitation can take anywhere from 3 to 6 months, depending on your progress and adherence to the program. We'll regularly assess your milestones and adjust the plan as needed.
Are there any activities I should avoid during recovery?
Yes, avoid any high-impact activities or movements that could strain your surgery site. We'll provide you with a list of do's and don'ts to guide you.
Now look at question 26.
Good afternoon, Miss Lee. Please have a seat. I have your test results and would like to discuss your diagnosis with you.
Thank you, doctor. I've been really worried about what the tests might show.
I understand your concerns. The scans and blood tests indicate that you have stage 2 breast cancer. The good news is that it's localized, which means we have several effective treatment options available.
Stage 2, what does that mean exactly?
Stage 2 means the cancer has grown but hasn't spread to distant parts of your body. It's still early enough that we can manage it successfully with a combination of surgery, radiation, and possibly chemotherapy.
What are my next steps? What treatment do you recommend?
First, we'll schedule a meeting with our surgical team to discuss the possibility of a lumpectomy or mastectomy, depending on your preference and the specifics of the tumor. Following surgery, radiation therapy is typically recommended to eliminate any remaining cancer cells.
Are there any side effects I should be aware of with these treatments?
Yes, there are potential side effects. Surgery may involve some pain and a period of recovery. Radiation can cause skin irritation and fatigue, while chemotherapy might lead to nausea, hair loss, and increased risk of infection. We'll manage these side effects to ensure your comfort.
How effective is this treatment plan?
With stage 2 breast cancer, the 5-year survival rate is quite high, especially when treated promptly and effectively. Our goal is to not only treat the cancer, but also maintain your quality of life throughout the process.
I appreciate the information, doctor. It helps to know what's ahead.
Now look at question 27.
Hello, Mr. Thompson. How are you feeling today?
Hello, Emily. I'm managing, but some days are tougher than others.
I'm sorry to hear that. I'd like to talk about how we can better manage your symptoms to make you more comfortable.
I appreciate that. The pain has been quite challenging lately.
We can adjust your pain medications to ensure you're getting adequate relief. Additionally, have you tried the relaxation techniques we discussed during our last visit?
I've tried deep breathing, but sometimes the pain is too intense to focus on that.
Understandably, we can incorporate guided imagery or gentle massages to help distract from the pain. Would you be open to that?
Yes, that might help.
Great. Also, let's discuss managing your fatigue. It's important to balance activity with rest. Scheduling short naps and conserving energy can make a big difference.
I've been feeling exhausted all the time, even after resting.
We can explore medications that help with energy levels and ensure you're getting proper nutrition to support your body. Speaking of which, how has your appetite been?
It's been pretty poor. I don't have much of an appetite.
We can consult with a nutritionist to create a meal plan that includes foods you enjoy and that provide the necessary nutrients. Sometimes smaller, more frequent meals can help.
That sounds manageable.
Additionally, emotional support is crucial. Would you like to speak with a counselor or join a support group?
I think talking to someone could help.
I'll arrange that for you. Remember, we're here to support you in every way possible. Let's schedule a follow-up to see how these adjustments are working for you.
Now look at question 28.
Good morning, everyone. Thank you for joining today's session on updated pre-travel health advice. As global travel increases, it's essential to stay informed about health precautions to ensure a safe and healthy journey. Firstly, vaccinations are a critical component of pre-travel health. Depending on your destination, you may need vaccines for diseases such as yellow fever, typhoid, hepatitis A and B, and meningitis. It's advisable to consult with a travel medicine specialist at least 4 to 6 weeks before your trip to allow time for immunizations to take effect. Secondly, malaria prevention remains a priority in many regions. Prophylactic medications, along with measures like using insect repellent, wearing long sleeves, and sleeping under treated bed nets, can significantly reduce the risk of mosquito-borne illnesses. Thirdly, food and water safety cannot be overstated. Travelers should adhere to the boil it, cook it, peel it, or forget it rule to avoid gastrointestinal infections. Carrying a water purification method or using bottled water is recommended in areas with questionable water quality. Additionally, travelers should be aware of environmental factors such as extreme temperatures and altitude. Proper hydration, sun protection, and gradual acclimatization can prevent conditions like heat stroke, sunburn, and altitude sickness. Mental health is also an important aspect of travel health. Being aware of the signs of stress and having strategies to manage anxiety can enhance your travel experience. It's crucial to have comprehensive travel insurance that covers medical emergencies. Carrying a basic first aid kit and knowing how to access local healthcare services can be invaluable in unexpected situations.
Now look at question 29.
Hello, Mrs. Martinez. How have you been since our last appointment?
Hi, Dr. Chen. I've been feeling better, but I'm still struggling to maintain a healthy weight.
I'm glad to hear you're feeling better. Let's talk about combining proper nutrition and exercise to help you achieve and maintain your weight goals.
Yes, I've tried dieting before, but it's been hard to keep the weight off.
That's a common challenge. Sustainable weight management involves a balanced approach. Let's start with your nutrition. Are you following any specific diet plan?
I've been reducing calories, but sometimes I feel deprived.
It's important to create a calorie deficit, but not at the expense of essential nutrients. Incorporating a variety of fruits, vegetables, lean proteins, and whole grains can help you feel satisfied while managing your intake.
That makes sense. What about portion sizes?
Portion control is crucial. Using smaller plates, measuring servings, and being mindful of hunger and fullness cues can prevent overeating. Additionally, limiting processed foods and sugary beverages can make a significant difference.
I can do that. How should I incorporate exercise?
Aim for at least 150 minutes of moderate aerobic activity each week, such as brisk walking, cycling, or swimming. Complement this with strength training exercises twice a week to build muscle mass, which helps boost your metabolism.
I enjoy walking, so that should work for me.
That's great. Consistency is key. Find activities you enjoy to make it easier to stick with your routine. Also, consider setting realistic goals and gradually increasing the intensity or duration of your workouts.
I'll try that. Are there any other tips for maintaining a healthy weight?
Yes, staying hydrated, getting adequate sleep, and managing stress are all important factors. Sometimes emotional eating can hinder progress, so addressing those underlying issues can be beneficial.
Now look at question 30.
Good afternoon, colleagues. Today I'll be presenting the recent study results on managing hyperlipidemia, which has significant implications for our clinical practices. The study, conducted over 5 years with a diverse population of 10,000 participants, aimed to evaluate the effectiveness of various interventions in controlling lipid levels and reducing cardiovascular risks. One of the key findings is the superior efficacy of statin therapy in lowering LDL cholesterol levels. Participants on high-intensity statins experienced a 50% reduction in LDL levels compared to those on moderate or low-intensity doses. Additionally, the study highlighted the benefits of combination therapy. Patients who received statins alongside ezetimibe or PCSK9 inhibitors showed enhanced lipid-lowering effects and a greater reduction in major cardiovascular events. Lifestyle modifications remain a cornerstone of hyperlipidemia management. The data reaffirm that dietary changes, increased physical activity, and weight management significantly contribute to lipid profile improvement. Notably, the Mediterranean diet was associated with the highest compliance and positive outcomes. Furthermore, the study addressed the role of patient adherence. It was observed that adherence to medication regimens and lifestyle changes correlated strongly with better lipid control and lower incidence of heart disease. In terms of safety, the research found that statins were generally well tolerated, with only a small percentage of participants reporting muscle-related side effects. Regular monitoring and individualized therapy adjustments were recommended to mitigate these risks. The study emphasized the importance of early intervention. Initiating lipid-lowering therapies in individuals with elevated risk factors can prevent the progression of atherosclerosis and reduce long-term cardiovascular morbidity and mortality.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear 2 different extracts. In each extract, you'll hear health professionals. talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Let's start with the basics. How would you define shock in a clinical context?
Shock is essentially a state of inadequate tissue perfusion and oxygen delivery, leading to cellular hypoxia, organ dysfunction, and potentially multi-organ failure if not promptly addressed. It's a cascade that begins with impaired oxygen delivery and can escalate rapidly if the underlying cause isn't managed effectively.
Understanding shock's pathophysiology is vital. Could you elaborate on the oxygen cascade and its role in shock?
Certainly. The oxygen cascade refers to the series of steps involved in delivering oxygen from the environment to the cellular level. It starts with ventilation, breathing in oxygen, which is then absorbed in the lungs and transported by hemoglobin in the blood. Cardiac output plays a critical role in maintaining adequate perfusion pressure, ensuring oxygen reaches the tissues. At the cellular level, mitochondria utilize this oxygen for metabolic processes. Any disruption in this cascade, whether it's impaired ventilation, reduced cardiac output, or cellular dysfunction, can precipitate shock.
Diagnosis is often challenging. What are the key clinical indicators you look for when assessing a patient for shock?
The primary approach is clinical evaluation. We assess heart rate and blood pressure, as tachycardia and hypotension are common signs. Skin manifestations are also telling. Whether the patient is warm and flushed or cold and clammy can indicate the type of shock. Mental status changes, such as confusion or decreased consciousness, suggest impaired cerebral perfusion. Additionally, monitoring urine output provides insight into renal perfusion. Biochemical markers like elevated lactate levels and metabolic acidosis further support the diagnosis. These indicators collectively help us infer the patient's hemodynamic status, as detailed in the Harvard Intensive Care Guidelines.
Let's incorporate a case study to contextualize these concepts. Imagine a 65-year-old male patient presenting with confusion, tachycardia, and hypotension after a severe abdominal infection. How would you approach his management?
In this scenario, the patient is likely experiencing septic shock, a subtype characterized by widespread vasodilation and increased vascular permeability due to infection. The initial management focuses on restoring adequate tissue perfusion. This involves fluid resuscitation with crystalloids, typically administering 30 milliliters per kilogram as recommended by the Surviving Sepsis Campaign guidelines. Concurrently, initiating broad-spectrum antibiotics is crucial to address the underlying infection. If the patient remains hypotensive despite fluid administration, Vasopressors like norepinephrine should be started to maintain mean arterial pressure above 65 mmHg.
Fluid management seems pivotal. How do you determine the right balance in fluid resuscitation without causing fluid overload?
Assessing fluid responsiveness is key. Techniques such as passive leg raises or using dynamic measures like pulse pressure variation can help determine if a patient will benefit from additional fluids. It's important to monitor for signs of fluid overload, such as pulmonary edema or increased central venous pressure. In our case study, if the patient's hemodynamics stabilize after initial fluid administration, we might limit further fluids and consider vasopressors instead.
What role do vasopressors and inotropes play in managing shock, particularly septic shock?
Vasopressors like norepinephrine are first-line agents in septic shock to counteract vasodilation and maintain adequate blood pressure and organ perfusion. Inotropes such as dobutamine may be added if there's evidence of myocardial dysfunction or persistent hypoperfusion despite adequate blood pressure. The choice and dosing of these medications depend on the patient's specific hemodynamic profile. For instance, norepinephrine is typically started at 0.01 to 0.1 mg/min and titrated to achieve the desired mean arterial pressure.
Monitoring is essential during treatment. What parameters do you continuously assess to ensure effective management?
Continuous monitoring includes vital signs like heart rate, blood pressure, and respiratory rate. We also track urine output as a marker of renal perfusion and use central venous or arterial lines for real-time blood pressure monitoring. Additionally, serial lactate levels and central venous oxygen saturation can provide insights into the adequacy of tissue perfusion and the effectiveness of our interventions. Advanced monitoring techniques, such as echocardiography, can also assess cardiac function and guide further management decisions.
In cases where standard interventions aren't sufficient, what advanced therapies might you consider?
If a patient doesn't respond to initial fluid resuscitation and vasopressor therapy, we might explore additional options like corticosteroids, which can help reduce inflammation and improve vascular responsiveness to catecholamines. Mechanical support devices, such as intra-aortic balloon pumps or extracorporeal membrane oxygenation, may be necessary in refractory cases. These interventions require a multidisciplinary approach and are typically managed in specialized intensive care units.
Finally, prevention and early recognition are crucial. How can healthcare teams improve outcomes for patients at risk of shock?
Education and training are fundamental. Ensuring that all healthcare providers can promptly recognize the signs of shock and understand the protocols for early intervention can significantly improve patient outcomes. Implementing standardized sepsis protocols and utilizing electronic health records to flag at-risk patients are effective strategies. Additionally, fostering a culture of teamwork and communication in critical care settings ensures that patients receive timely and coordinated care.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Cancer of unknown primary, commonly referred to as CUP or MUO, is a significant clinical issue, representing about 2 to 3% of all cancers globally. Despite its relatively low incidence, it accounts for the 5th most common cause of cancer-related deaths in the UK alone, underscoring the severity and complexity of managing these cases. Mark, could you elaborate on what exactly we mean by cancer of unknown primary?
Certainly. Cancer of unknown primary refers to metastatic malignancies where the primary site of origin remains unidentified despite comprehensive diagnostic investigations. According to the National Institute for Health and Care Excellence guidelines established in 2010, this definition requires extensive evaluation, including biopsy and histopathological analysis of the metastatic tissue. These guidelines have provided a clearer framework for diagnosing CUP, which historically was somewhat nebulous.
That's a crucial point. Without a known primary, treatment strategies become less straightforward. To delve deeper, let's consider a case study to illustrate the diagnostic and management challenges associated with CUP. Imagine a 65-year-old female patient named Mrs. Thompson, who presents to her general practitioner with significant weight loss and persistent fatigue over the past 2 months. Upon further evaluation, a CT scan reveals multiple liver metastases and a nodule in the right upper lobe of the lung. Given these findings, what additional information would be essential at this stage to guide further management?
In Mrs. Thompson's case, the initial presentation suggests a metastatic disease, but identifying the primary tumor is paramount for targeted treatment. Key information would include her performance status, which assesses her general well-being and ability to carry out daily activities. This is often measured using the Eastern Cooperative Oncology Group Performance Status Scale, where a lower score indicates better functional status. Additionally, understanding her past medical history, including any previous cancers, comorbid conditions, and current medications, is essential. This helps determine her suitability for further investigations and potential treatments. For instance, if she has a history of breast cancer, metastatic breast cancer might be a consideration. However, if no primary is evident, comprehensive investigations, including specific imaging and possibly molecular profiling, would be necessary.
Performance status is indeed a critical factor. In oncology, a patient's ECOG score ranges from 0, indicating full activity, to 5, which denotes death. For Mrs. Thompson, assuming she has an ECOG score of 1 or 2, she might be a candidate for further diagnostic procedures. Mark, what would be the next steps in managing a patient like Mrs. Thompson?
If Mrs. Thompson is deemed fit for further investigations, a structured diagnostic pathway should be followed. This typically begins with a thorough clinical examination and detailed history taking to identify any subtle signs that might suggest the primary site. Radiologically, a CT scan of the chest, abdomen, and pelvis is standard. In her case, given the pulmonary nodule, additional imaging such as a PET CT scan might be warranted to detect hypermetabolic lesions indicative of primary tumors. Furthermore, tissue biopsy is essential. The metastatic liver lesion should be biopsied to obtain histopathological and immunohistochemical analyses, which can provide clues about the tissue of origin. For example, markers like cytokeratins, TTF1, and others can help differentiate between possible primary sites such as the lung, breast, or gastrointestinal tract.
Biopsy and histopathological analysis are indeed the cornerstones of diagnosing CUP. However, even with extensive testing, a primary site may remain elusive. In such cases, how do we approach treatment, especially considering the prognosis associated with CUP?
The prognosis for CUP is generally poor, with median survival ranging from 6 months to a year, depending on various factors including the extent of metastasis and the patient's overall health. Treatment is often empirical, based on the most likely primary sites suggested by the clinical and pathological findings. For instance, if the histology suggests a lung primary, platinum-based chemotherapy regimens similar to those used for non-small cell lung cancer might be employed. However, with advancements in molecular diagnostics, there is potential for more personalized treatment approaches. Gene expression profiling and next-generation sequencing can sometimes identify the tissue of origin or reveal actionable mutations that can be targeted with specific therapies. This precision medicine approach holds promise for improving outcomes in CUP patients.
That's an exciting development in the field. Now let's discuss the resources and support systems available for healthcare professionals managing CUP. Mark, are there specific teams or pathways in place to assist clinicians?
Yes. According to the NICE guidelines, any cancer center should have a dedicated CUP team. These multidisciplinary teams typically include medical oncologists, radiologists, and other specialists who collaborate to provide comprehensive care for CUP patients. In our region, NHS Lanarkshire has established a CUP diagnostic pathway, complete with referral procedures and contact points to ensure timely and coordinated management. Additionally, national guidelines provide detailed recommendations on appropriate investigations and first-line management steps, which are invaluable for both oncologists and general practitioners. Access to these resources ensures that patients receive evidence-based care tailored to their specific clinical scenarios.
Early referral and multidisciplinary collaboration seem pivotal in managing CUP effectively. Are there specific scenarios where urgent oncology intervention is required?
Absolutely. Oncological emergencies such as spinal cord compression, hypercalcemia, or superior vena cava obstruction necessitate immediate attention. For instance, spinal cord compression can lead to irreversible neurological deficits if not treated promptly with steroids and possibly radiotherapy or surgery. Similarly, hypercalcemia of malignancy requires urgent management with hydration, bisphosphonates, and sometimes dialysis in severe cases. In such emergencies, swift communication with the oncology team is crucial to initiate appropriate interventions and improve patient outcomes.